All right. Let's talk about thromboembolism. So whenever you admit patient as an intern or resident, there are some things, those are very common and we do it all the time. Among them, one of them is a prophylaxis for thromboembolism. So the rationale behind giving anticoagulation as a prophylaxis for thromboembolism, because most of the patients they are admitting, they are kind of ill, and also they are going to be immobilized for some period of time, and those are the very strong risk factor for development of embolism. Could be DVT, or could be pulmonary embolism. So that's why we always give them the prophylaxis. So whenever patient came, the first thing you need to understand, if patient is already on any blood thinner, which could be because of AFib or any stroke prevention, whatever the reason is. If patient is on any blood thinner already, you can continue those medication while doing a medric. If patient came with a stroke or any bleeding, then you would like to hold those anticoagulant. But if there is no any contraindication, you can continue all the blood thinner patient has been already taken. And if patient's not on any blood thinner, you need to start the anticoagulation. So there is a score that we always do, we call the Padua score. I'll show you at the end of this video, but for now I would like to show you what are the options. So there are two good options mostly we give whenever we admit patient for anything. So the option that we have are enoxaparin or unfractionated heparin. So how much we give? So mostly it depends on like the dose is kind of same. Mostly we give a 40 milligram enoxaparin subcutaneously daily, or unfractionated heparin 5,000 units subcutaneous Q8 or Q12. And so which one is the best option? So if patient doesn't have any renal failure, if kidney functions are okay, then enoxaparin 40 milligram subcutaneous daily would be ideal. If patient have a kidney disease, like the kind of severe kidney disease, we always consider a heparin 5,000 units subcutaneously Q8 to Q12, or you can choose Q12 would be a good idea if so two option, enoxaparin or unfractionated heparin. Mostly we start enoxaparin if kidney functions are okay. If kidney functions are not that good, you can just go ahead and start unfractionated heparin 5,000 units subcutaneously Q8 to Q12. And enoxaparin mostly are like daily, once in a daily. And so this is kind of summary of anticoagulation. So mostly anticoagulation we give for two reasons. One is prophylactic, which we just discussed, and the other is therapeutic. So therapeutic we'll discuss another video. For now, just focus on therapeutic. So therapeutic, we mostly start enoxaparin of 40 milligram subcutaneously daily, or 5,000 unit heparin Q8 to Q12, depending upon the kidney function. If kidney functions are good, you can start enoxaparin. If not, you always consider unfractionated heparin. So these are the two main anticoagulation we use. Now let's talk about the Padua score. So we do Padua score for all patients who came with like admission. So let's talk about if patient have reduced mobility, like if patient is going to admit for more than 3 days or something like that. and if patient is elderly and our patient is obese, then you calculate the score, and based on the score, mostly if the score is less than 4 is a low risk of VT. If score less than 4, we give case by case. Patient still you think are high risk, you can give, otherwise you can skip it. If score is more than 4, we always give a thrombo, like a prophylaxis for thromboembolisms. And if there is any contraindication, you can give the mechanical.